Hi, Dr. Brian Kaufman. I'm a family physician, a doctor turned patient with CLL, learning a lot at ASH 2013 in New Orleans, and I'm here with my friend Dr. Jeff Sharman, who's done some interesting research. You want to introduce yourself, Dr. Sharman?
Yeah, my name is Jeff Sharman. I'm a hematologist-oncologist, and I'm the medical director for U.S. Oncology Hematology Research.
So, one of the things that you pointed out that's a little unusual about this meeting is that there's a number of phase 3 trials. First, remind us what a phase 3 trial is and why is that unusual for there to be a significant number of them?
In drug development, you generally have phase 1, 2, and 3 studies. One is largely about finding a dose that's that's safe. You go up slowly on the dose, try to find where you're running into side effects, and hopefully at the end of that you have a good sense for what the right dose is. Do you want to get into that?
No, we're good.
Okay.
Keep going, yeah.
Phase 2 studies are primarily early looks at efficacy. So now you take a defined population and you try to map out whether or not a drug is...
And both of these are usually single-arm trials.
Oftentimes there can be arms based on different types of disease.
Right.
You might have different cohorts, or and sometimes there's randomization, but for the most part they tend to be single-arm.
You're usually not like a placebo-controlled or a standard therapy versus, yeah.
So then phase 3 is where you try to prove a point. And oftentimes to prove a point you need a very large study and you need a randomization where all the variables that patients bring with them into a clinical trial, you get a flip of a coin, you know.
Yeah.
So you end up either in this group, and you don't have a choice. And it's uncommon in cancer studies for there to be a placebo with nothing that's active, but it's not uncommon to have perhaps an established therapy in which a new drug is added to the combination, or perhaps a placebo in the other arm.
Right, and I would say from a patient's point of view, some of these may not be placebo, but when you're talking about some of the older drugs like chlorambucil or even single agent rituximab on their own, they may not be placebo, but they're hardly a potent standard of care therapy that you would be using as the other arm.
Well, I think that serves as a good springboard for even some of the phase 3 studies that are here, and I think this is where these conferences are interesting, because you see personalities in real time lining up on either side and poking each other in the nose over, you know, what this does mean when there is a positive phase 3 study, just what that means. And what you're alluding to, I think, is one of the big challenges of clinical trial design. What is an appropriate standard therapy arm? In some cases that's really straightforward, in some cases very difficult. So one of the phase 3 studies that's approved, or that's being presented here, will be the randomization of patients to Rituxan plus placebo or Rituxan plus idelalisib. Okay, so this is one of the new drugs everybody's really excited about.
Right.
Roughly a 220 patient study, so it's a pretty good size, roughly 110 each arm. And what it's going to show when it's presented here shortly is that, not surprisingly, there's an enormous difference in response rates. The actual response rate to Rituxan alone, depending on how you define response rate, but by standard criteria, is actually in the mid-single digits. It does control the white blood cell count for a period of time, but then the cancer gets going again, versus response rates that are really quite a bit higher. And if I recall, I think the percentage is in the 80 or 90% range. So it's an enormous difference between the two arms. We calculate these things called p-values. What's the likelihood that this observation occurred by chance? And I've never seen a p-value that size in a clinical study ever. And the response rate difference is 10 to the minus 30th.
Wow.
So these are very different arms. Now, the critics will say, but Rituxan isn't an appropriate therapy. Well, I'll just say there's two sides to the argument, and your viewers can decide. There have been two.
Let me,
Yeah.
on that, I just have to ask,
Yeah.
from a patient's perspective, was there a crossover in that? So if patients
Yes.
progressed
Yes.
on the placebo arm, they could cross over to the other
Yes.
arm? So that was built in from day one?
Built in from day one.
Well, thank goodness,
Yeah, and I think it needs to, in a study where the control arm is perhaps as controversial as Rituxan, having that crossover, I think, mollifies some of the sort of moral concern
Right.
about the drug, because everybody would potentially have access to the experimental
And
drug.
it's got to help with enrollment too. I mean, if this is my
Unquestionably.
way to
Yes.
get to a drug that I want, I'm
Yes.
guaranteed to get it if I progress, and if I don't progress, then I don't need it.
Right,
Right.
right. So that certainly helped sell it, but then in theory, if there is a magnitude of difference in how patients do in the long term, perhaps giving them the chance to
Right.
cross over might narrow.
Right, you're going to
those
lose that
differences.
data, but
You're gonna lose
not
it.
at the cost of patient's
Potentially.
life. Yeah.
Correct, right. So these are how we sit around tables and fight over things
Right.
when we're getting studies up and going.
Right.
And I do believe everybody's trying to do what's right, but sometimes it's
And it's a new error because, you know, it's the moral difference between a drug that offered maybe a 40% versus a 30% chance.
Mhm.
You know, you could make some arguments
It's
to
tighter.
shift,
Yeah.
But when you've got like a
10
single
versus
digit
90.
90,
Yeah.
then it's very hard to make a moral argument not to allow the crossover.
Right, right. These are the points. So I'm going to come back to Rituxan monotherapy
Yeah.
because this is something I want your viewers to be aware of. There were roughly, I think 2 or 3 studies. There are 2 on my mind. There may have indeed have been a third one. I think there was in the front line of Rituxan monotherapy. And I think most academic docs would say Rituxan's largely insufficient therapy. It's not great therapy on its own in CLL. And it can oftentimes fix the blood count numbers, so maybe you jump up and down and say,
Right.
we've done some
Cosmetically, it looks good.
Yeah, I think that's exactly right. Sometimes things
You
look
shrink some
cosmetically
nodes.
better. But the progression-free survival, how long that works, is generally less than half a year. And in theory, you're giving somebody a drug that may lower the immune system to somebody who may already be immunocompromised. That may be a bad thing to do, right? However, if you look at patterns of care data in North America, somewhere between 20 to 30% of patients may receive Rituxan monotherapy at some point. So where's the disconnect? Oh, where's the disconnect? If you look at the average age of CLL at diagnosis, it's 71. If you look at the average age of first therapy, it's 74. Average age of death for CLL is in the late 70s. If you look at FCR trials, the average age is 61 at the time of treatment. So perhaps as many as 13-year difference between patients who accrue to those studies versus the average person who is getting their first-line therapy. So there's a big difference here between what happens in research studies and what happens in real life. And I think that there is some great concern expressed by some that Rituxan is an inappropriate control arm, and yet it's done so frequently. So what is an acceptable standard of care? Sometimes in the eye of the beholder. So the study at least tried to get those patients who are ineligible for typical chemotherapy. We know if your kidney function is not working so well, or if you have a lot of medical issues as well, comorbidities, maybe you're not appropriate for a chemoimmunotherapy approach. Long story short, this study was very similar. Progression-free survival was less than 6 months. Incidentally, ofatumumab was approved on the basis of a progression-free survival of 6 months. So these are relatively short benefits, and the median progression-free survival on the idelalisib versus the idelalisib with Rituxan has not been reached. And what I think was a surprise, I think what's a surprise in this study is it shows an overall survival benefit. This is something that doesn't happen much in CLL studies, where we show that something we do makes somebody live longer, and so that really makes this an important study.
So I think we're going to pause there for a minute, but this overall survival, because I remember the very first overall survival was the FCR study, the German 7. Eight,
Yep.
yeah, that was the very first one. That was just a few years ago.
Mhm.
And now we're getting overall survival in over
Yeah.
65 groups with obinutuzumab, and now you're telling me about an overall survival plan. So an exciting time. Thanks very much. We'll take a quick pause here.